POCUS webinar on fake outs and pearls for the hospice and primary care physician. My name is Kang Zhang, and I'm the Associate Program Director for the Internal Medicine Residency in Spokane. And POCUS has been a passion of mine for several years, and I really wanted to share this with you all. I think as POCUS becomes more prevalent in internal medicine, it is really important to recognize some of the pitfalls in image acquisition and interpretation. We've got an awesome lineup of presenters, from trainees to POCUS fellows to really nationally recognized experts in the field of POCUS, just to highlight some of the common pitfalls, and hopefully that you can scan more confidently when the next time you pick up a probe. So if you have any questions at this webinar, I will field all the questions at the end of this webinar. Huge thank you to our presenters, and as you can see, they're coming from all over the country. Liz, a big thanks to you for ongoing coordination of this, and to Dr. Holland, who has been very supportive of POCUS education at Washington ACP. So we'll get our first presenter started, Dr. Trevor Jensen, coming from UCSF.
Good evening, and thanks for having me. My name's Trevor Jensen. I am a hospitalist in San Francisco at UCSF. I head our divisional efforts in point-of-care ultrasound training for our faculty, and also assist with training for our internal medicine residency and medical students. I think I'm taking the lead here and introducing the first case, and I'm going to be talking about GU POCUS, specifically around renal POCUS. And while admittedly this is not the thing that I do the most often, or do I necessarily think it's the most pivotal exam in internal medicine POCUS, my hope here is to talk through a few of the high yield points to cover that are hopefully illustrated by this case and useful in your future use of point-of-care ultrasound. Before I jump into the case, a quick faculty disclosure. So I am a consultant, a paid consultant for Caption Health. That is an artificial intelligence company that works on ultrasound guidance and interpretation, but is not really related to the content of this point-of-care ultrasound webinar. I'm going to introduce a case that came late in my residency, and why I mention that is most of the cases that really drove me to use point-of-care ultrasound occurred in that level of training for me. They really ended up being pivotal in cases that I otherwise was going to have challenge solving, and that really drove me to integrate point-of-care ultrasound into my sort of daily care of patients in hospital medicine. Though relatedly, because it was so early on and before we had the ability really to store anything, I've supplemented the actual images with ones from colleagues or later on. So I appreciate those being provided. So jumping in here, this is a 26-year-old man with an unknown past medical history who presented to the emergency department at UCSF with altered mental status. They sent off an initial metabolic laboratory evaluation and noted a bunch of abnormalities. So he was admitted to medicine for further investigation and workup and treatment of his altered mental status. When we first went down to evaluate him, we noted that he was borderline febrile, mildly tachycardic, had some soft but otherwise hemodynamically stable pressures, and was satting well on room air. He was sleeping but woke to sternal rub, had a normal HENT, cardiovascular, and lung exam for the most part. And then on abdomen was maybe his only focal finding. It was soft but diffusely tender to palpation, worse in sort of the infraumbilical area. And on neuroexam, he withdrew to pain, sort of woke up as he did on the abdominal exam, moved all extremities, but didn't follow commands. And as noted above, he had several laboratory abnormalities, including a white count of 16, a hemoglobin of 15.5. He was mildly hyponatremic and acidotic, and had an elevated BUN and creatinine of 43 and 2.1. His CK was 5,500, and the UA that was positive for hemoglobin WBC esterase with 10 to 20 whites. His tox screen then came back positive for multiple things, including methamphetamine, MDMA, and opiates. So as I do with basically any new patient evaluation or any change in clinical status for a hospitalized patient, I asked myself, is there a role for point of care ultrasound here? And I think an important part of asking that question is framing the patient's problems with respect to point of care ultrasound. So his major problem probably is altered mental status, but for me, that doesn't have a really specific algorithm or set of exams to interrogate with respect to point of care ultrasound. That said, he has additional problems, which include acute kidney injury and abdominal pain. And for me, both of those have specific paradigms and exam sets that may be useful in investigating depending on the clinical context. And I would argue that together, in this patient's case, they have even a more specific set of exams that could be useful. And the first thing to note is to go down to the area of abdominal pain. And in this guy's case, that was infraumbilical. And we took a look in that area, and this is what we saw. And so this is a large bladder. You can see that the down here is 21 centimeters, which basically says that the diameter and width are at least in the teens. So the next thing we do in this case, it's worthwhile to get a quantitative or semi-quantitative measurement. And you can do this pretty easily. You can freeze the frame and just take the calipers and move across to your width and depth. And in this guy's case, they were 13 and 15. To get the full sort of volume of the sphere, you would actually then rotate into the longitudinal approach and get the length. We won't do that here. But those three volumes, those three data points allow you to calculate a sort of semi-quantitative volume of their bladder. And in this case, I'm using one of the calculations. So 13 times 15, which were those measured diameter and depth. Let's say the length was 10 in the other view, which we're not showing here. And then you multiply it by a constant, which is often quoted somewhere between 2/3 and 3/4. But regardless of what you use for that last number, the volume of this bladder was over a liter. So 1.5 is what we calculated. So given that he has a lot of abdominal pain, this can probably explain his abdominal pain with how disseminated this is. But the question is, does this help explain his AKI? And so to further investigate that, we moved up to the kidneys. And here's what we saw. So this first one on screen left is the patient's right kidney. Notable anatomy, you have the liver overlying the kidney here. We're fanning or tilting through the long axis of the kidney. Notable that there's no fluid here. There's a negative spine sign, so there's no fluid in the lungs. But what we're really interested in is this renal collecting system, this renal pelvis. And our initial read here was actually, this actually looks a little dilated, right? You see this hypoechoic or black area here, right in the pelvis, which could suggest mild or moderate even hydronephrosis. And that would be consistent with the clinical picture that we see. So then we moved over to the left side to take a peek. We said, if the obstruction is distal to the bladder, causing enlarged bladder volume and potentially hydronephrosis on the right side, that should potentially lead to hydronephrosis on the left side. And here's what we saw here. Again, to orient, this is going towards the head. This is the spleen, the splenorenal interface, which does not show any fluid. And then this is his kidney. And we noted here what we thought might also be a mild hydro, this hypoechoic area adjacent to the collecting system. And so our initial interpretation here was possible mild to moderate hydronephrosis. But what we did next was to clarify and really get a more granular sense of, is this truly hydronephrosis? And this is something I honestly didn't know at that time. And I had my mentor actually teach me this, and we ultrasounded. And we threw color over that right kidney, that renal collecting system. And we noted that actually all of those areas that we thought might be hydronephrosis lit up with color Doppler, and they were pulsatile. And this is suggestive of actually vasculature, sort of prominent vasculature in that right kidney area, rather than hydronephrosis. So while there's fluid in hydronephrosis, it should not be pulsatile like this. And this is basically diagnostic of prominent vasculature and rules out hydronephrosis in this case. And so we went back to the left kidney to say, hey, that's weird, right? We thought we had bilateral hydro. Is that also what's going on the left side? And we threw color over this one, not shown here, and it didn't actually light up. So we thought, is that unilateral hydronephrosis? But as we looked closer and fanned through both the longitudinal axis and the transverse axis, we actually noted that these were perihilar, but they weren't actually in the collecting system. The rest of the collecting system was hyperechoic, as we would expect. And so in the end, we thought that these were most consistent with perihilar cysts. So bringing this together, ultimately, we did not think that there was any hydronephrosis, and it's worth talking a little bit about point of care ultrasound for acute kidney injury. And that is that hydronephrosis sensitivity and specificity are actually, just okay. Different studies say different things, but they're in the 70 to 95% range. And it's worth noting, 3 in 10, 1 in 4 cases where you think there's hydronephrosis, there actually may not be. And in this case, if you didn't throw those extra evaluations on there and recontextualize, you probably would have missed it. So other important data that's sort of peripheral to this case, but important in point of care ultrasound for acute kidney injury, is that hydronephrosis itself is not very sensitive for AKI for urinary retention. If you just look at the kidneys, you will not often see hydronephrosis. So in this case, they could have AKI from urinary retention. It just could be too early, and they have not yet developed hydronephrosis. So in this patient, it doesn't actually rule out an obstructive cause. That said, if this patient truly had hydronephrosis and the urinary retention that we know is present, that would be a really good positive predictive value for causality. So if that had been true hydronephrosis, in this case, we could have said with high confidence that obstructive renal failure was probably playing a role in his AKI here. So back to this case, how do we interpret it? He certainly has urinary retention, that's real, of unclear etiology, potentially toxicology based with his opiates and or methamphetamine. We don't see any evidence of hydronephrosis, and ultimately his AKI is still rather undifferentiated with pre-renal versus pigment versus post-renal all possible. Resolution of this case, the rest of the exam, we placed a Foley, got 1.2 liters of clear urine out, and his AKI improved rapidly with gentle hydration. His mental status then improved over the next 24 hours, and we were able to discontinue the Foley without issue, and he passed a void after. So as a last slide, we'll drive home a few teaching points about GU POCUS. And that is that the benefits are that it's pretty easy to obtain these images, right? Both from a kidney perspective and a bladder perspective. These take a couple seconds to minutes, and they're high fidelity. You can often get the images. It can add value to the question of obstructive renal failure. So ultimately, this was pretty nuanced, but both the bladder and the renal ultrasound can add value in the right clinical scenario as long as you do the exam comprehensively. And in this case, even though we didn't, ultimately answer the question of obstructive renal failure, it did obviate the need for further imaging, right? So when we found that this patient had a gigantic bladder and we decompressed it, his bladder felt better. And lastly, it can help identify obstruction above the bladder. So if you're looking for hydronephrosis, or if you find hydronephrosis, even the absence of bladder distension, you can diagnose obstructive renal failure in a selected patient population. And in internal medicine, places where I work, where metastatic cancer is a huge cause of intra-abdominal pathology, it can be helpful to figure out what's going on in the kidneys that way. But it does come with some risks. So as we saw here, some normal anatomic variants can lead to false positive interpretations. And then even with the correct interpretation, The clinical integration is a bit more nuanced and limited than many other exams, right? So positive hydronephrosis does not necessarily mean that's the cause of your AKI, and vice versa. So integrate it as one piece of the puzzle, and just be sort of humble in your use of POCUS in this particular area. That's all I've got. Thank you so much, and I'll be around for questions.
Trevor, that was excellent. Thank you for that. I was actually just faked out by a renal cyst mimicking hydronephrosis not too long ago. I'm hoping you can help me answer, how do you archive and storage images at your institution? And what do you do for Q&A?
Yeah, thanks so much for having me, and happy to answer a little bit about how we do it here. So the short answer is we've had many systems of archival and QA actually over the years. And I think what I'll try to do is sort of explain a little bit of the process in 1 to 2 minutes, just to meet, I think, a lot of where you guys are at, right? So there's some places that have impeccable archiving and QA processes. I know Dave Tierney and some other people on here have achieved that, but I think most of us live in a place where sort of we have to cobble together various different resources. So in my opinion, sort of there's no one size fits all. At UCSF, we've actually elected not to hook up all of our machines to PACS EMR, partly because of how challenging it is to do that and maintain it, just the administrative burden. And partly because we're still in an early phase of training most of our faculty. So most of the images we get shouldn't sort of go up there and live in the PACS EMR. And we have elected not to sort of use a middleware program like QPath for the moment. So we actually, it's all organized really around sort of the training apparatus and the QA for those people who are credentialed. And those people who do sort of use POCUS and are credentialed, they, since we don't bill for it, they just type in their notes what they've found basically, and that works for sort of clinical documentation. But from a QA process, we have a monthly QA basically meeting, image review, which includes sort of all our trainees, sort of medical student all the way up to hospice. And we review sort of the monthly images that have been obtained in our various different machines. We have 4 different brands. So they live in different places, either a secure box or sort of the butterfly cloud and things like that. And we have either our fellow or director of credentialing, whoever's sort of in charge of that month's image review, sort of pull all the images, go through them monthly and sort of get interesting ones, fake out clinically challenging cases that were identified over the month. So still a work in progress, even for us, even though we've been doing it 5 to 10 years.
Great, thank you.
Happy to answer some of those questions in the chat while you move on.
Awesome, very good, thank you. All right, next is Dr. Brittany Ward. She is a resident in internal medicine residency, Spokane.
Hello, my name is Brittany Ward. I'm a second-year internal medicine resident at Providence Sacred Heart in Spokane, and my presentation is titled Follow Your Heart. I have no conflicts or disclosures. My case is a 58-year-old female with history of ischemic cardiomyopathy, hypertension, coronary artery disease, status post PCI and stent placement 7 days prior. She presents to the ED today with a chief complaint of 3 days of progressive exertional dyspnea. She states today she had difficulty walking up a flight of stairs and experienced significant shortness of breath, which is different from her baseline. She also admits to a new dry cough that developed over the last 2 days. She denies orthopnea or chest pain. She is compliant with her medications and has not missed any doses, with the only new medication being the Plavix after the stent placement. Otherwise, her previous medications included lisinopril, carvedilol, furosemide, aspirin, and atorvastatin. She denies any recent travel, sick contacts, or change in diet. Her vitals showed a temperature of 37.9, a blood pressure of 126/62, a heart rate of 114, a respiratory rate of 20, and she was satting 92% on room air. On physical exam, she was not in any respiratory distress, but noted fine bibasilar inspiratory crackles. She was tachycardic, but no murmurs or rubs were noted, and she had no appreciable JVD. Her EKG demonstrated sinus tachycardia without acute findings or ischemic changes. Up to this point, without POCUS, the differential remains broad but includes a pericardial effusion given her recent cardiac catheterization procedure with stent placement, with clinically new exertional dyspnea and tachycardia. Also on the differential includes acute coronary syndrome given her history of CAD, although her EKG was reassuring and she is not clinically having chest pain. Given her history of cardiomyopathy, also must consider acute heart failure exacerbation, although she had no JVD on examination. And she was borderline febrile with her vitals, therefore considering a pneumonia versus viral syndrome. And lastly, given the dyspnea, the new dry cough, as well as the tachycardia, must consider a pulmonary embolism. So our initial POCUS examination included starting with the parasternal long axis view. In this view, you can see the left ventricle located centrally within the screen here. And just above that, you can see the right ventricle. And then this demonstrates the left ventricular outflow tract and the left atria. Within this view, you can see the descending aorta as well at the bottom of your screen here. This view demonstrated a hypoegenic structure anterior to the RV, which initially was concerning for a pericardial effusion, this structure up here. However, further evaluation with examining this descending aorta closely, it does not appear to have an anechoic fluid collection anteriorly, which would represent a pericardial effusion. The second cardiac window obtained was the apical forechamber, with the ventricles closest to the probe, located here, and the atria seen here. On this view, we do not see a circumferential anechoic collection surrounding the heart within the pericardium, which is reassuring that this patient does not have a pericardial effusion. And the last view obtained was the subxiphoid forechamber view, which shows the RV located here and the LV located here. In this view, you can see that speckled appearing hypoegenic fluid collection that moves synchronously with the cardiac motion. We also do not demonstrate a circumferential fluid collection or any of that anechoic fluid posteriorly surrounding the LV. The POCUS fakeout demonstrated by this case is the anterior epicardial fat pad. It is the most common mimic of a pericardial effusion and usually visualized on the parasternal long axis view located just anterior to the right ventricle. It is described within the echocardiogram literature as a speckled appearing structure that moves synchronously with the baseline cardiac motion. Because it is anteriorly located, it is never circumferential. However, you must know that all pericardial effusions may not also be circumferential if they have a loculated component to them. Once aware of this common POCUS fakeout, several steps can be taken to further assess the findings as either an epicardial fat pad or pericardial effusion. In the parasternal long axis view, by visualizing the descending aorta and being able to assess for any fluid collection anterior or posterior to this may be helpful in determining if the patient does have a pericardial effusion. The subxiphoid view can also be used to identify a pericardial effusion versus a fat pad by scanning anteriorly and posteriorly, as the fat pad is always located anteriorly without any posterior component to it. And the apical view can help visualize the presence of a circumferential anechoic fluid collection, which is consistent with a simple pericardial effusion. The American Society of Echocardiography, the expert consensus statement published in 2013, included the figures seen on this slide, which clearly demonstrate the location of the epicardial fat pad seen in figure 1, which is located here. And adjacent to that in figure 2 and 3 are screenshots of complete transthoracic echocardiograms. And in figure 2, the findings of a pericardial effusion with an acute taper point anterior to the descending aorta is seen here. And anterior to the RV is this speckled appearance with an anechoic fluid collection just superior to that, the presence of both an anterior fat pad as well as a pericardial effusion. And figure 3 is just basically a zoomed in version of that, with the RV located here, the epicardial fat pad here with this speckled appearance, and then a pericardial effusion located just anterior to that. So what is the current evidence out there, or why do we care about this? A recent retrospective study performed at a single academic center in Canada enrolled 342 patients who had a pericardiocentesis done during admission and reviewed the clinical presentation, the physical examination findings, chest x-ray, EKGs, time to diagnosis, and time to pericardiocentesis, and how the use of POCUS impacted the findings and the hospital course. The results showed that average time to diagnosis with utilization of POCUS was 5.9 hours compared to greater than 12 hours with use of other imaging modalities, including the official echocardiogram. And the average time to pericardiocentesis with use of POCUS was 28.1 hours compared to greater than 48 hours with the other diagnostic tools. Therefore, POCUS can aid in expediting the time to diagnosis and treatment of clinically significant pericardial effusions. For my specific case, POCUS was used to help exclude the diagnosis of a pericardial effusion, even with the presence of an anterior epicardial fat pad. The patient was ultimately treated symptomatically for a viral pneumonia. My take-home points for this case include that the anterior epicardial fat pad is the most common mimic of a pericardial effusion. The epicardial fat pad always moves synchronously with the cardiac motion and is always located anteriorly, with no circumferential presence. When using the parasternal long axis view, visualizing the descending aorta can help distinguish the presence of a pericardial effusion if an anechoic fluid collection is located anteriorly. And like in everything in medicine, multiple data pieces lead to a more precise diagnosis. Therefore, utilizing the several different cardiac POCUS views will help paint a more complete picture, and that will be able to support a diagnosis of a pericardial effusion. Again, I'm Brittany Ward, and I thank you for watching my presentation on POCUS fakeouts with a focus on the anterior epicardial fat pad.
Great. Thank you, Brittany. I love that, last statement, one view is no view. My question for you is, you're still in training and trying to figure out how to, your style of practice, and how has POCUS changed the way you evaluate patients?
Yeah, thanks, Kang. So for me, I recently have just begun utilizing POCUS more so on the inpatient side. I actually just got off a rotation of nights, which we do most of our admissions during that time. And so I really think POCUS in the undifferentiated patient has been the most helpful for me, as well as using it on cross-coverage patients when the clinical scenario has changed significantly where you need to reevaluate. But I think it was already said earlier that you have to know which clinical question you're trying to answer with POCUS. Otherwise, it can just be confusing or adding kind of, data points that don't make sense with other data points. So I think really just making sure that clinical questions you're asking, and then use it as a piece of the bigger puzzle, along with vitals, how the patient looks clinically on physical exam as well, and laboratory data. And so for me, I really appreciate it. I think I have been able to really better treat patients, more so with like the chief complaint of shortness of breath as they come in, being able to assess the lungs for B lines and take a quick glance at the heart and just assess, preserved EF or decreased EF to give me a general view of either volume status or heart failure component. And then I hope to continue to grow and use some more of like the abdominal exams as I get to work more with Kang in training here at Spokane.
Whoops, sorry. So our next presenter is Dr. David Tierney. He is the program director at the Abbott Northwestern Internal Medicine program and the director of Internal Medicine Bedside Ultrasound program. So I'm going to get this going.
All right, here we go. We're going to call this pitfall no antibiotics for lunch. No disclosures. This is 69 and comes in cardiogenic shock. Emergently undergoes a 5-vessel cab and comes out of the operating room with a balloon pump in place. Does well for a couple days, and then on day 3, his morning labs have a little bit of a white cell count, and that evening, after the primary team is gone, his oxygen requirements increase a little bit, and his temperature climbs up a little bit. When the nurse talks to him, he says he's got a little bit of a cough. So a chest x-ray is ordered, and on the chest x-ray, the question is, what's in the left lower lobe? Does he have some atelectasis there? Does he have an infiltrate? Does he have a little bit of fluid? So that is sort of the often chest x-ray question. And the resident who's on that night is asked to go see him and sort out that left lower lobe with ultrasound. What is it? Is it fluid? Is it atelectasis? Is it pneumonia? By the primary team. So the night flight resident heads up, and on the walk up to the patient's room with the ultrasound, starts to think through in the head, all right, I'm going to look for pneumonia here. What all can pneumonia look like on ultrasound? And it's a big spectrum, right? In the upper left-hand corner here, you see a completely consolidated left lower lobe with dynamic air bronchograms extending and contracting, a little bit of pleural fluid around it, and then here's the diaphragm. So 0 air other than in the bronchial tree. Here you see not quite as socked in. This is an upper lobe here. This is the apex of the thorax right here. So air bronchograms again, these white dots, consolidated lung, and then as the patient's breathing, you get some B lines in the adjacent, more aerated lung, but a pneumonia. Down here in the bottom left, just some small areas of peripheral-based pneumonia, consolidation here underneath the visceral pleura, with a bunch of B lines at the area where that re-aerates. And then down here it can just be B lines, right? Some focal B lines or diffuse B lines for an interstitial pneumonia. Here's a floodlight of B lines in a left lower lobe in a different patient. That could be pneumonia. So the spectrum of what could pneumonia look like in this patient is broad as you go and look at him. The patient's laying down and can't sit up, is lightheaded and a little bit short of breath. So the resident puts the probe in the left mid-axillary line. The patient's obese, so it's somewhat difficult. And in that position, sort of mid-axillary line on the left with the indicator towards the head, this is a coronal cut. This is what the resident sees, and it looks very much like what they were thinking when they were walking up that they would find. Here, there is some area of unaerated tissue here with some little white dots in it. There's some bright white around it with some B lines coming off of that. And this tissue here is moving down and up with respiration. And this looks just like what they thought they were going to see, a pneumonia there. So they say, yeah, this is somewhere, it's not totally sucked in. What I'm seeing is somewhere between this example of pneumonia and this small peripheral-based consolidation, somewhere between those two. And they start that patient on antibiotics for a left lower lobe pneumonia. So what's the problem? The problem is not about antibiotic choice here. It's about what we're looking at on ultrasound. And if you put the probe in the mid-axillary line or the anterior axillary line on the left, and you take a coronal cut, this is what you're looking through, depending on how high up you are, whether you're in the abdomen or thorax. If you take this cut, you go through lung, if you're up high enough, or you go through spleen first, if you're down in the abdomen. If you go through spleen, then you end up in stomach. Okay, stomach is sitting anteriorly here in the left upper quadrant. And what we're going to do now is if we slide our probe or we fan our probe posterior, so now we're looking posterior, then you see more spleen and the left kidney. But if we fan back anterior, you go through the spleen maybe, but you're seeing mostly stomach. If you slide your probe posterior and put your knuckles on the bed on the posterior axillary line, it's harder to find stomach, and here you're really looking at spleen and left kidney. So you've got a high potential for seeing stomach if you are sitting on the mid-axillary or anterior axillary line and you're down just a little bit too far. Down just a little bit too far might be in a spot where in a normal person you're in thorax. But if someone has an elevated hemidiaphragm, has a lot of ascites or is post-operative from a CV surgery like this guy, has a paralyzed diaphragm, whatever it might be, when the diaphragm is elevated, the stomach can creep up here into a spot that you would normally expect to see lung. And if we look at the virtual ultrasound here of what that cut looks like, you get a little cut through spleen, and then this is representing the stomach here, okay? And up here you see just barely the lung tip sneaking in with some A-lines here just underneath that rib shadow. If I take away that marking over what the stomach is, the stomach in this example is fluid-filled and black, okay? It's not always fluid-filled, it can often have air in it. So as you fan here, okay, now watching, you're gonna get rid of stomach as you fan posterior, and now you get spleen and kidney, and that's a very identifiable abdomen there. But when you're more anterior, it's harder to tell. If you slide your probe posterior again, then you get spleen and kidney, and now you can see, all right, I'm an abdomen very clearly, and then you can march up knowing that now you've entered into lung. So the error of looking at stomach and thinking it is thorax is most often made when you're not posterior enough with your probe, your knuckles on the bed. Here's what it looked like in our patient. So again, we're cutting through just a little bit of spleen here and then seeing stomach. This is air-filled stomach here. And if you slid posterior, you would now have spleen and kidney in this guy. So again, the initial view here, that looks very much like pneumonia and sliding like a lung would. There's a little bit of spleen up there that catches your eye, and if you fan and slide way posterior, then it becomes very obvious that you're down below the diaphragm in the abdomen, and this is not pneumonia at all. This is an air-filled, fluid-filled stomach that also has these B-lines coming from it, but clearly this is abdomen, and lung is off the top of the screen here because this hemidiaphragm is quite elevated in this patient. So how can you avoid this? First of all, your knuckles on the bed being really posterior. You go a long way away from the stomach when you're posterior, and it's harder to make this error mistaking stomach for consolidation. The other thing is if you think about this consolidation on this CT scan here, which would look like a fully socked in hepaticized lung, like you see here, this image would look like that. If you moved just out of the completely consolidated center to this lighter area around it, this is not normal lung. When you have a pneumonia consolidation, the adjacent tissue is not normal. It's always this penumbra of ground glass interstitial B-lines on ultrasound. Like you can see here, you've got a consolidated area, and then adjacent to it, you've got all these B-lines. You don't have normal lung right up against consolidation. If you look at the image on the left, which is from the abdomen, and watch what happens here, the patient has movement again, which looks kind of like lung sliding, but here you're looking at spleen and stomach. Okay, so this is the fake out again in the abdomen, a little bit of spleen in the near field, and aerated stomach here. But the key on that is that if you look at what happens when you take a really deep breath in here, you can see that this is normal lung sliding in with A-lines here. And if you have normal lung immediately adjacent to what you think is consolidation, so normal lung on the left coming in and this you're calling consolidation, you should think again because you would expect consolidation to be next to a bunch of B-lines, not immediately next to normal aerated lung with A-lines. So that's your lung tip coming in, and that's your clue that this is a fake out left lower lobe pneumonia, and you're about to give antibiotics for lunch to this person's stomach. Here's a few more stomachs just to make the point. Here's a stomach, a little spleen at the top, and again, sort of when it's air-filled stomach, it looks very much like pneumonia. If you slide posterior here, you're going to see spleen and kidney, and it becomes clear that you were an abdomen. If we go up here in the upper right, here's a more fluid-filled stomach. So again, medial to the spleen. Here's a fluid-filled stomach, and there's actually a feeding tube in this stomach here that you can see. There's diaphragm there, and you're down in abdomen. And then lastly, here's another tricky one where it looks maybe like consolidated lung and some air bronchograms here, being a pneumonia, but this again is below the diaphragm here. And this is the left lower lobe pneumonia fake out, looking at the stomach through the spleen. So take home points when you're looking at the left lower lung region, especially for pneumonia. Have a little filter that says, could this left hemidiaphragm be elevated? If so, I might think I'm in the thorax, but I'm actually looking at the abdomen. And if you're a little bit mid-axillary line or anterior, you might see stomach instead of spleen and kidney. And the stomach can be confusing. It sits in front of the kidney and the spleen, and don't feed it antibiotics. Put your knuckles on the bed. That'll help with this. Go way posterior when you're questioning it. And then just remember that if you see what you think is consolidation immediately next to A lines in normal lung, you might be getting faked out, because normally there's a transition from consolidation to B lines to normal lung when you're looking at a pneumonia. All right, thanks very much. All right, we're going to call this one the eyeball is connected to the... He was 23 and he came in with asthma. He's got a long history of asthma, but no other medical problems. This time he had a little bit of a fever, and about 3 hours after he came into the hospital at about 2 in the morning, he's got some vague chest pain and becomes quite hypotensive and tachy. He looks like he's in respiratory distress as well. And on exam, he's got new crackles, has bilateral lung sounds, and the sense clinically was that he was in cardiogenic shock. They got a chest x-ray, and it was not impressive, shown there on the right. And it was wondered, is this a PE then? But what are the crackles about? So a lung ultrasound gets done in spite of the relatively normal chest x-ray on this young guy. And he's got not clean lungs. So he has a bilateral diffuse interstitial process there that you can see with B lines throughout. So this is not straight asthma. And then someone grabs a quick look at a parasternal window on him in an effort just to answer, does he have normal systolic function or not? Their eyes look just here at the left ventricle that's visible. This is the base of the LV, the basal segments, and he looks normal dynamic there. So he doesn't have a really reduced left ventricular function at the base. And they move on feeling like this is not cardiogenic shock from low systolic function. Here's the problem. First of all, the part of the heart that we're seeing when we get the parasternal lawn axis, the part of the left ventricle, is really just the basal segments, and you're missing the mid and the apex of the left ventricle. The value then in a second window, which they got after a little bit of time, is that here's a normal reference apical forechamber. This is not his. Here's the left ventricle, and here's the right ventricle. The left ventricle always tapers as it moves from the base to the apex. It never gets wider as you go from base to apex. Over here is the apical forechamber they got of this young guy, and when you look at it, in green here, here's the base of the LV. That's the part you were seeing here on the parasternal lawn axis. That's squeezing quite normal. There's no reduction in function there. But what you don't see on the parasternal lawn axis is the mid and the apex, which is completely akinetic when you go out to the apical window. So one of the pitfalls of eyeballing LV systolic function at the point of care is to think that you're making an assessment of the LV function in the parasternal lawn axis window alone. It's a great window, it tells us a ton of stuff, but it's missing the mid and the apex of the left ventricle. And especially when the apex and the mid segments are out, like in this case, this could be Takotsubo stress cardiomyopathy. This could be an LAD lesion. The base often becomes hyperdynamic and tries to make up for its sidekicks there. So you can look here and think you've got a normal systolic function, but you're missing the apex. The other thing they found on this young guy when they went back and had a little more time to look closely at something other than just are you squeezing, was that there's a vegetation on the aortic valve that you can see right there. And then also the left atrium is big, which is a little bit strange in a young, healthy guy. So your brain should go to the mitral valve when that happens. That regulates the LA pressure during systole. And this is a little more subtle, but you can see a little vegetation hanging out on that posterior leaflet of the mitral valve right here as well. So he had aortic and mitral valve endocarditis, and he had thrown part of this vegetation to his LAD. So he went emergently to the cath lab in florid cardiogenic shock, and had an embolectomy from his LAD and came out and was on ECMO for 3 days, and then decannulated and did just fine. So that's one pitfall of LV systolic function assessment at the bedside. I'm going to point out a couple other ones. Let's look at these two parasternal lawn axis windows. Here you've got, again, the base of the left ventricle and the mid left ventricle here. And when you look at this chamber squeezing here, that diameter changing, and you compare it to this ventricle over here, this left ventricle, your eyeball thinks that this heart is squeezing more than that one is, that the function of this ventricle is a little more hyperdynamic than that one. The key is that these are both the exact same heart, and this ventricle is in plane. You've got the mitral valve and the aortic valve visible, and there is not a papillary muscle visible here, so you're right down the center of this cylinder in this view here. And if you were getting the perfect parasternal lawn axis and thinking of it as a cut through the parasternal short axis, this is where that plane should be. It shouldn't have a papillary muscle in it, and it should be through the widest part of the ventricle. If you fan a little bit off axis, you make the ventricle look smaller, you make the walls closer to kissing each other, and you often make the chamber even smaller by bringing in this papillary muscle here, which you can see in plane right here. So the difference between these two, it's the exact same heart, it's just that the heart on the left is the plane right down the center on the green line, and the heart in the upper right here is an off-axis or parasternal lawn, which is a cut like this. So before you ask yourself about systolic function, you should make sure you're in the right plane, having both valves in plane and being in the widest part of the left ventricle. You can't really underestimate systolic function with this air, but you can overestimate it and think things are a little more hyperdynamic when you're off on one of these yellow lines. All right, let's take these three parasternal short axes and compare them. And I want you just very quickly to look at the three of them and tell me which one is the best systolic function and which one has the worst systolic function. And if I asked you for the most hyperdynamic heart or the best function, I think, without listening to you, that most people think B up here in the upper right is the best function. And if I asked you the worst function, I think you would say C down here in the bottom middle. And the key to this pitfall is that when you eyeball systolic function, your brain loves to make tachycardic hearts have better function, and bradycardic hearts have worse systolic function. And these are all three the exact same clip. This one in the upper left, A, is the original clip. This one is the same clip slowed down by 50%. And this is the same clip sped up by 50%. So your eyeball likes to make letter B there seem like it's got better squeeze than letter C, but it's just a lens of tachycardia overlaying that, and they're exactly the same. So be aware of that pitfall. here's one more pitfall that's related, that this person can be in florid cardiogenic shock with an ejection fraction of 90%. All right, here's the left ventricle short axis, and that is a kissing ventricle with a 90% EF. And the key is that EF isn't the end all be all, right? The stroke volume coming out of this heart is terrible. So EF is just one piece of the puzzle, but you can be in forward flow heart failure with a normal EF. If you have no stroke volume, this is hypertrophic cardiomyopathy. And one more step here. Here's our friend that we started with, who had mitral and aortic valve endocarditis, and we said he's got a big left atrium. So we should look at the valve, and we did. And we saw a little vegetation there that was subtle, but he's got mitral regurg. That's this blue jet here, going away from the probe. And one other assessment piece is that the stroke volume, okay, which we said probably is more important than the ejection fraction. The stroke volume that comes out of the left ventricle can go two places. You hope that it all goes out the aortic valve, but if someone has mitral regurg, like this, a part of it goes backwards, and then the other part goes out to the rest of the body and the kidneys and all of those pieces. So EF's not the end-all be-all. Stroke volume by area change of the left ventricle is not the end-all be-all. It's really how much is going out the aortic valve that you care about. And someone with bad mitral regurg, all that's going out of the ventricle is not necessarily going out of the aortic valve to the body. So those are a few quick little LV function pitfalls. Just remember what we said. EF isn't stroke volume. Stroke volume's not even the end-all be-all. It's how much is going forward. And really what we care about is cardiac output, because that's what cardiogenic shock is about. Your brain loves to make faster hearts have better function, and slower hearts or beta-blocked hearts have worse function. So just be aware of that lens. Remember that the parasternal lawn axis is great, but it only shows you the base and maybe the mid segments of the heart. It doesn't show you the apex, which can have trouble. And when the apex is slacking, the base often tries to make up for it, and even looks more normal than at baseline. And then just remember there's a rationale to us talking about get the right plane first and then compare sizes of things or compare function at that point, because when you're out of plane you can either overestimate or underestimate different things with cardiac ultrasound. All right, hopefully that's helpful.
All right, Dave, thank you. Your talks are always so great. You know, you've supervised a lot of residents and gone through a lot of scans. What do you do with incidental findings?
Yeah, that's the tough question. And I think the key to the answer in that it's got the word findings in it, that you found it. You didn't not see it, you found it. And the reality is we all have consciences and we all have the ability most of the time to get additional testing. We're not in such limited settings that we can't get additional testing. So incidental findings are found. And if you don't know what they are at the point of care, there is an escalation in imaging that typically follows that. Unless you have someone you can take the ultrasound machine to down in radiology and show it to, and they say, oh no, that's a Hampton's hump. It's not a tumor on the left kidney. Unless you've got those in place, it often results in additional imaging. You hope it's not real expensive, and you hope it is not radiation based, and you hope there aren't downstream effects. But the reality is that when you look at point of care ultrasound coming into an institution or into a new provider, there is an increase in referral imaging most of the time. For us in the IMBIS program, it went up and it didn't come back down to zero until 18 months. That was a year and a half of pretty robust implementation of point of care ultrasound. After that 18 months, it has stayed below the baseline for the last 12 years. So there is a gain down the road, but it results in additional imaging. And you hope that the relationships with cardiology and radiology at your site allow you to take some of them down there and say, can you tell me what this is, or if I should get another test? That's not always the case, but it helps avoid some of it when you can.
Great, thank you for that, Dave. Our next presenter is a ultrasound fellow at Mass General.
The patient that we'll be discussing today was a 70-year-old male who presented to our hospital with dyspnea and hypoxemia. His past medical history was notable for diffuse large B-cell lymphoma, for which he had failed several lines of therapy. At the time of presentation was on palliative immunotherapy. He had an ischemic cardiomyopathy with a known ejection fraction of 22% on his last transthoracic echo, and he also had paroxysmal atrial fibrillation, for which he was not on systemic anticoagulation in the setting of pretty profound cytopenias related both to his lymphoma and the treatment thereof. He also had recently been admitted to our hospital for septic shock requiring vasopressors and an ICU admission. His shock at that point in time was thought secondary to multi-organ failure and sepsis, more so than anything related to his underlying cardiomyopathy. At the time of the patient's presentation, we performed bedside ultrasound, which was notable for the following. First and foremost, here you can see a parasternal long axis view. Perhaps as is expected in the setting of his known atrial fibrillation, his left atrium looked a bit large. The patient also had known large malignant pleural effusions, and you can see a left pleural effusion tracking down beneath the left ventricle in the image here. As expected, based on his known ejection fraction, certainly his function appears reduced here with an EPSS that is certainly greater than 7. But overall, there was nothing acutely surprising based on the patient's known past medical history in this scan. We didn't have a parasternal short axis view, so the next image that you're seeing here is a subxiphoid view. Again, here you can see the large left pleural effusion, and there also is perhaps a trace pericardial effusion, although the clinical picture was not in any way suggestive of tamponade physiology, and this was thought trivial, if anything. Otherwise, there were no new findings on the subxiphoid view to support anything new diagnostically as etiologic of the patient's hypoxemia. We then obtained an apical 4-chamber view. And again, when focusing on our POCUS questions with cardiac POCUS, you can again see the reduced function of the left ventricle, which does appear pretty globally hypokinetic with an ejection fraction or function that is certainly reduced. The right ventricle certainly appears smaller than the left ventricle, as would be expected in a normal heart, and again, there's no significant pericardial effusion. However, in this view, we noted something that was a little bit unexpected, which was a fixed hyperechoic structure, which seemed to be non-mobile and located in the left ventricle. This had not been viewed in the other aforementioned pictures, but we got a second apical 4-chamber view with a little bit of fanning through. And again, you can see this large fixed immobile structure, which again appears a bit hyperechoic and seems to be located in the left ventricle. The patient then got an apical 3-chamber or LV inflow view, which again focused on specifically that structure which we were concerned about in the left ventricle. And again, you can see that it appears to be located perhaps in the same location, fixed and immobile, and not in any way contracting with the heart. I will point out again here that inferior to the left ventricle, you can again see that large left pleural effusion, which does seem to be surrounded by lung tissue, which may be a bit consolidated as well. And so our differential diagnosis at this point was somewhat broad. We were uncertain what was in the left ventricle, but we were thinking about things like a left ventricular thrombus primarily, particularly as the patient was not on systemic anticoagulation. We also were wondering if this could be a foreign body, an artifact of vegetation, particularly as the patient had recently been admitted for pretty profound septic shock, maybe some sort of atypical calcification. But ideally, we would have had more views, including a parasternal short axis view. However, again, as we reviewed previously, this really only seemed to be apparent on the apical 4-chamber. And so we were left with the question, is this fact or is this an artifact? And we were really working together clinically at the bedside to figure out how to take care of this very sick patient, and POCUS did help to guide us in his care, but at the same time, this finding was a bit puzzling, and we were curious if this could be related to his clinical presentation. In reality, when thinking about whether or not you have a LV thrombus, which was the primary question on our minds at this point in time, I think there are 3 M's that can help you to identify whether or not you have a thrombus or not. On the right side of your screen, I'm going to play the bedside ultrasound, again done by our department, of a patient who had confirmed both left ventricular and right atrial thrombi. I will use this patient to explain the rules that I think can help us to tease out whether or not we have a fact or an artifact. The first M is motion. Assess for wall motion abnormalities. We all know that stasis drives clot formation, and in the absence of stasis, meaning if you have a completely normal ejection fraction or LV function on bedside echo, it's a little bit tough to really have a thrombus in that setting. Parasternal long and parasternal short axis views are going to be your key views in this setting to help you identify whether or not the function is normal. We also should always be careful to image in multiple planes. The pictures that I showed you just previously of our patient with dyspnea were notable for the fact that the only view that showed any evidence of thrombus or an atypical finding was the apical 4-chamber view. If there is an abnormal finding, you should be seeing it repeatedly in multiple views, and making sure to confirm its presence in multiple planes can help you to be clear on whether or not what you're seeing is actually something real. The final would be to confirm whether or not the structure is fixed or moving. As you can see in the picture playing on the right side of your screen, the structures in the left ventricle and right atrium are moving with the heart throughout the systolic and diastolic phases. This is because, as would be expected, something that is attached to the wall of the ventricle or atrium is moving with it. This is in contrast to our patient, where there seemed to be a fixed and immobile structure within the heart. This is unexpected. If something is in the heart, you would think it should be moving along with it. So all of these things, and when we applied the 3 M's, made us suspicious that we were dealing with an artifact and not, in fact, a left ventricular thrombus. I'm going to again show you 2 more clips of the patient who had a confirmed left ventricular thrombus, that one that was just playing on the right side of your screen, just to point out that within the parasternal long and short axes, you again see that left ventricular thrombus present repeatedly and in the same place along the left ventricular myocardium. This again confirms that the patient had in fact an abnormal finding, and this is the opposite of our patient, where we only again saw that abnormal finding in one view. So confirm in multiple planes. When we're performing point-of-care ultrasound, it's important to be recognizing the artifacts that can show up on our bedside scans, because they can make us make calls that are wrong or incorrect in some way. And so the first set of artifacts that it's important to recognize are those of reflection, refraction, and related to the equipment itself. A lot of these we're pretty familiar with: reverberation, acoustic shadowing, mirror artifact, which you're seeing a nice example of on the right side of the screen here, refraction artifact, and near field clutter. We won't be spending a lot of time discussing these today. However, there are also artifacts which can be related to the ultrasound beam itself, and these are side lobe artifact and beam width artifact. Beam width artifact, again, we won't be discussing in great detail, but I'm going to spend some time discussing side lobe artifact because we had high suspicion that this is what was happening to our patient at the bedside. The way that I would describe this is as follows. As the transducer sends a signal to the object of interest, for example, the left ventricle, the ultrasound crystals expand and contract to produce the primary ultrasound beams in the direction of the expansion and contraction, effectively up and down. However, secondary beams also occur because the crystals also do expand and contract radially. And so these secondary beams essentially pick up things that are in the periphery of the field of view. However, the transducer is not smart enough to know that those signals are coming from the periphery. It interprets everything as coming from directly in front of it in the direction of the normal crystal expansion. So that is to say, if there's something sending a strong signal in the periphery of the transducer's view, almost like our peripheral vision, the transducer cannot correct for that, and it transposes that image into the field of view, effectively taking something that is not in the left ventricle and making it appear as if it is there. These artifacts are important, and they are often seen in the setting of bowel gas or very hyper or anechoic structures, fluid-filled structures, things that can easily transmit signal or send strong signal back to the transducer located in the lateral field are the areas where you're most likely to have this happen. And this graphic, I will give full credit to those who described it, a group of echocardiographers, some of whom were at Massachusetts General Hospital here with us. And so if I return to the LV inflow or apical 3-chamber view for our patient, you can see that the lung tissue is a strong reflector on the lateral aspect of the image. And our suspicion is high that it's actually this lung tissue and consolidation thereof that sent a strong radial signal that created side lobe artifact and then transposed into the left ventricle in this patient. And in fact, he did have a formal echocardiogram which showed no evidence of LV thrombus, again confirming that this was an artifact. And so the point that I would like us to take away is that artifacts matter. So what we see and what we think we see can be different in the setting of point-of-care ultrasound. It's important to know artifacts because we can easily overcall things that are not there, and to recognize that our eyes can be deceived just as the receiver can be deceived. There are, of course, expected atypical findings or artifacts, things like the Coumadin ridge or the RV moderator band that we all know to be careful of as well, and that can make us better point-of-care ultrasonographers. We should also focus our POCUS. We try very hard within our division to stick to our standard POCUS questions, and then if we see something that is outside of our expected frame of view or things that seem a bit atypical, we often then at that point in time refer to a higher level of diagnostic care, whether it be formal echo or formal other diagnostics at the bedside. And then we should really be cautious with what we call, this patient actually initially was called to have an LV thrombus on bedside ultrasound and then again had the formal, which did not show that. And it was a reminder to all of us that we should be careful with what we see and what we call, and always have a pretty high threshold or a pretty low threshold to ask for someone else to guide us along the way. Thanks so much for having me join you today. This is my email address and my Twitter. I'm happy to discuss any POCUS things at any point in time, and here are my references.
Kathleen, thank you so much. And I apologize, I skipped your introduction slide. So if you can introduce yourself to everybody again. And then I also have a question for you, would be, what are your top 3 to 5 POCUS resources?
No worries at all. My name is Kathleen and I'm an ultrasound fellow in the emergency department at Mass General. And then I just finished my residency in June. And so I'm also working as a hospitalist for the remainder of my clinical time. I had also in my intro given some a shout out to Irene Ma, who's on the Zoom today. She helped with the development of this as well. In terms of resources that I use, we spend a lot of time in our fellowship teaching learners at the bedside and working with them to sort of guide them through evidence-based point of care ultrasound. And so I find both the POCUS Atlas and then I have the Evidence Atlas app on my phone, which I find helpful for pulling up things like likelihood ratios and things like that at the bedside that I don't always have memorized. I also like to listen to the Ultrasound Gel podcast. I find that's really helpful in terms of walking through the new data or new studies that have been done. Sorry, there's probably a fire on my street. And then finally, I really like when I was starting as a POCUS fellow, but even now, I use emergencyultrasoundteaching.com. They have a group of narrated lectures that are really helpful and have sort of, I think, collaborated with people from all over to come up with a group of lectures that are helpful for all different POCUS modalities. So any of those, I think, will not steer you wrong.
Awesome, that's wonderful. And I recognize a lot of people here on this, that's part of this webinar who are also very POCUS, masters of POCUS. And if you could just all kind of type in your favorite resources for all of us, so we can that you can all share, that would be wonderful. So moving on is Dr. Laura Chen, also a POCUS fellow from Cornell.
Hi, my name is Laura Chen, and I'm a POCUS fellow at Weill Cornell in New York. My presentation is titled, Don't Panic! I have no conflicts of interest to disclose. We have a 51-year-old male with a history of polysubstance abuse on methadone, history of L4 to L5 and L5 to S1 discitis and osteomyelitis in the past, sent by his primary care doctor to the ED for worsening lower back pain for the past 3 months. He had an MRI lumbar spine done as an outpatient, which was concerning for progressive L2 to S1 osteomyelitis and L4 to L5 discitis. His primary care doctor sent him to the ED for further evaluation after this MRI result. He denies any fevers, chills, urinary or fecal incontinence, numbness, tingling, or weakness. He also denied any trauma to the area. Social history reveals that he is a current smoker, he does not use alcohol, and he uses IV cocaine, last use about 2 to 3 weeks ago. He also has a history of heroin, methamphetamine, and marijuana use. Further history revealed that he was admitted to the hospital 1 year ago when he presented with generalized fatigue, night sweats, and excruciating back pain. At that time, an MRI lumbar spine was done and findings were suspicious for L4 to L5 and L5 to S1 discitis, osteomyelitis with involvement of the left psoas muscles. During his hospitalization, he received an L5 bone biopsy which resulted in Streptococcus parasanguinis osteomyelitis. At that time, blood cultures were negative and he was ultimately treated with ceftriaxone for 6 weeks. For his physical exam, Vital signs were normal. He's a thin male with poor dentition. The rest of his physical exam was unremarkable. He had no spinal tenderness or step-off, and he had a non-focal neurologic exam. Labs were normal, and his UTOX revealed positive for cocaine, methadone, and cannabinoids. A POCUS cardiac exam was performed. This is a parasternal long-axis view of the heart. Here we have the left atrium, mitral valve, left ventricle, which leads us to the aortic valve and the aorta. And this is the right ventricular outflow tract. This parasternal long-axis view is interpreted as normal left ventricular ejection fraction and no pericardial effusion. So pretty much a normal parasternal long-axis view. This is a subcostal four-chamber view. Initially, I was having difficulty obtaining the apical four-chamber view, so I actually obtained this view on the patient first. Here is the liver, which we are using as an acoustic window to see the heart. Here is the right ventricle, tricuspid valve, right atrium, left atrium, mitral valve, and left ventricle. And we also see a left pleural effusion here. But what is this hyperechoic structure in the right atrium near the tricuspid valve? Is it a vegetation? Let's take a look at the other views of the heart. This is the apical four-chamber view. I was finally able to obtain this image on the patient after some time at the bedside. Let's go over some structures. Here's the left ventricle, mitral valve, left atrium, right atrium, tricuspid valve, and right ventricle. In this view, I don't see the hyperechoic mass near the tricuspid valve anymore. Instead, I see the structure over here in the right atrium with a fibrin-like structure attached to it. Let's look at the last view, the inferior vena cava. Here is the last image in our cardiac POCUS exam, the inferior vena cava. The IVC travels through the liver to the right atrium. You see the hepatic vein here. Again, you see the hyperechoic structure more clearly now at the entrance of the IVC into the RA. If you look closely, the hyperechoic structure is not attached to the tricuspid valve, but instead it is attached at the entrance of the right atrium. This would be an unusual attachment point for an endocarditis vegetation. And we see this fibrin-like structure again in the right atrium. You can see that the fibrin-like structure moves with the flow of blood. It moves toward the tricuspid valve when it opens. This hyperechoic structure did fake me out to believe it was an endocarditis vegetation, but it is really an anatomic variant, a remnant of an embryonic valve of the inferior vena cava. We are going to talk about some background information on anatomic variants in the heart so you don't get faked out when you're doing a cardiac POCUS exam. Anatomic variants are common in the right atrium, and why is that? To answer this, we have to talk a little bit about embryology. During cardiogenesis, we have a primitive ventricle and atrium. Blood from the left and right sinus venosus drain into the primitive atrium through the left and right sinus venosus valves, which are not pictured here. The smaller left sinus valve becomes incorporated into the septum secundum, and the larger right valve becomes incorporated into the right atrium. Normally, the right valve regresses between the 9th and 15th gestational weeks. The cephalad portion of the right valve becomes the crista terminalis, which is the smooth muscular ridge in the right atrium, and the caudal portion divides into the eustachian valve and the valve of the coronary sinus. As you can see, most anatomic variants in the right atrium are remnants of the right sinus venosus valve. Incomplete regression of the right sinus valve can result in the eustachian valve, Chiari network, or a prominent crista terminalis. The eustachian valve is a remnant of the embryonic valve of the IVC. It directs oxygen-rich blood from the IVC to the interatrial septum and the left atrium of the fetal heart. If the eustachian valve does not completely regress, it looks like a crescent-like fold or leaf-like structure at the posterior margin of the IVC on ultrasound. Prevalence of the eustachian valve is about 4% on ultrasound. The Chiari network is a thin web-like fenestrate membrane that originates from the eustachian valve. Part of the Chiari network arises from the orifice of the IVC like the eustachian valve, so it is thought to be a variant of the eustachian valve. The Chiari network appears as a free-floating, curvilinear structure that waves with blood flow in the right atrium on ultrasound. Look for its attachment to the orifice of the IVC or to the upper wall of the right atrium to make this diagnosis. The Chiari network has been found in 1.3 to 4% of autopsy studies. Here is a table to review the differences between the right-sided endocarditis vegetation and the eustachian valve and Chiari network on POCUS. In endocarditis, the vegetation is usually attached at the tip of one of the tricuspid valve leaflets. The vegetation is usually round in shape, although not always, and the vegetation moves with the valve as it opens and closes. For an anatomic variant like the eustachian valve or Chiari network, the structure is attached at the orifice of the IVC or the upper wall of the right atrium. The eustachian valve is leaf-like or crescent-shaped, while the Chiari network looks like a free-floating curvilinear structure. Lastly, the Chiari network will move with the flow of blood in the right atrium. Back to our patient's clinical course. Neurosurgery was consulted and they did not recommend any surgical interventions. He ultimately received a vertebra core biopsy by IR, which pathology resulted in no osteomyelitis, but the bone had remodeling changes. Infectious disease ultimately recommended 6 weeks of empiric metronidazole and levofloxacin treatment. And looking through the patient's chart, he was known to have the Chiari network from prior echo reports. Some take-home points. Be aware of the right atrium anatomic variants, which include the Chiari network and the eustachian valve. Obtain multiple cardiac views so you can take a closer look at the attachment site of the structure in question. Again, it is more likely an anatomic variant if the structure attaches to the orifice of the IVC or the upper wall of the RA. When in doubt, obtain an official transthoracic echocardiogram to help in the diagnosis, or look at prior echo reports for any mention of anatomic variants. Sometimes you may need a transesophageal echocardiogram to distinguish the diagnosis. And finally, this goes without saying, but clinically correlate your POCUS images with your patient's presentation. Thank you.
Excellent. Thank you, Laura. As you're completing your internal medicine POCUS fellowship, and I don't think there's that many in the country, would you be able to enlighten us on what this year has been like for you?
This year has been a great experience. Obviously, I'm learning a lot of POCUS, ultrasound guided procedures, and a lot about POCUS literature. We learn a lot from the hospitalists who use the POCUS every day on the wards, but also from other specialties like radiology, cardiology, critical care, other proceduralists, and ultrasound techs. Of course, the POCUS field is growing, so not only do we learn about POCUS, but we also teach a lot of POCUS, which has been definitely a very rewarding experience.
Hi, this is Janice Bowden. I am an internal medicine physician at the Chaz Clinic in Moscow, Idaho, and I'm here to talk to you about how to use point-of-care ultrasound to evaluate for rib fractures and how to avoid this fake out. Our case is a 24-year-old man with severe chest wall pain after a car crash while intoxicated. He's been to the emergency room where they've done imaging of his head and C-spine, and when you see him, his vital signs are unremarkable. He's got a normal oxygen saturation, the blood pressure is a little tachycardic and afebrile, And when you examine him, he does have some mild bruising on his thorax. His lungs are clear, and his cardiac exam is normal. He says that when he takes a deep breath, it's painful, and in fact, you can see that. He requests strong pain medication for a cracked rib. So you want to find out if he has a cracked or a broken rib. But this is tricky. Identifying broken ribs on radiographs can be really subtle. A chest x-ray, in the most optimistic paper that I could see, may be no more sensitive than 60% in picking up rib fractures, especially terrible for below the diaphragm. Though rib films may be quite sensitive, most people don't get rib films. Getting a rib film or a set of rib films when you're in the hospital or in the clinic can be considerably more time consuming than just doing a point of care ultrasound yourself. Over the course of decades, I've gotten rib films and sometimes diagnosed rib fractures that way, but I'm much happier to use my point of care machine and look for them myself. Even a standard CT, the standard CT cuts are actually insensitive for rib fractures. And the sensitivity is even worse if somebody other than a radiologist looks at the films. This chest x-ray, which on casual glance looks quite normal to me, shows 3 traumatic rib fractures. We'll make it a little bigger. Do you see them? So I've looked at it quite a number of times, and so I now see them. And here's a hint. There are 3 of them on ribs 4, 5, and 6 on the right side. And there they are. So when you look closely, yes, you can see that there are rib fractures, but it definitely wasn't obvious. Point of care ultrasound is better. In one study back in 1999, that's a lot of years ago, they showed that point of care ultrasound could pick up as many as 6 times as many rib fractures as standard x-rays. So how do you do it? If it's that cool, it must be difficult. Well, no. You ask the patient where it hurts. You feel the rib with your fingers gently. Then you scan that rib in transverse and longitudinal orientations using an ample amount of gel on your linear transducer. You visualize the rib and you slide the transducer along the portion that's painful. If you scan the cartilaginous portion of the rib, that's an extra bonus because x-rays definitely can't see fractures of the costal cartilage. So here's a picture of a transverse scan of a long bone fracture. And so as you move your transducer along the bone, it's transfers to the bone. You see that the bone is at one level and then boop, all of a sudden it's at a different level. So that's the step off. There's a little bit of a discontinuity in the cortex of the bone. Longitudinal view. You see cortex of the bone, some stretched connective tissue, and the cortex of the bone. So this linear transducer is right along the top of that rib. Let's see the next one. Even cooler looking. There's your bony cortex, subcutaneous tissue. So in this one, the transducer is a little bit oblique, and so we see kind of a little parts of the bone. But here's the fracture. But what do you see down here? What's this thing here? It's kind of shimmery. Are we seeing 2 rib fractures? A little discontinuity here and another one here. No, that's the pleural line. So here's a nice picture of the pleural line. This is a view of this linear transducer is placed in such a way that there's a rib on the top, a rib on the bottom, and as the patient breathes, you see this shimmering. This is the parietal and visceral pleura moving across each other. We call that lung sliding, and it indicates that there is no pneumothorax. So is this a rib fracture? At first, it looks like it. So here's the bone, and here's the bone. Nope. This is the bone, and this is the pleural line. How about this? We just moved across, and now we've got, it looked like we were seeing multiple rib fractures, but we weren't actually, because these step-offs are actually rib sitting next to pleural line, as you would see with a rib and then an intercostal space. So you're definitely not seeing a rib fracture. Doesn't mean there isn't one, but you're not seeing it there. How about this one? Nope. There's the rib, but this is a shimmery line, so this is the pleural line. So, there we go. Is that a rib fracture? How about that? Yes, the left one is, and no, the right one is not. As you can see, that shimmery pleural line. Final take-home points. Scan for rib fractures. It's fun. It's easy. Use your linear probe. Scan where it hurts. Point-of-care ultrasound is more sensitive than chest x-rays for rib fracture. Don't be fooled by the pleural line. It shimmers, and it is not a bone. If you don't know if it's a bone or a non-sliding pleural line, because rib fractures can go with pneumothoraces, make sure of your orientation with respect to the ribs, and also scan transversely to look for that step off. So if you're truly on the rib, you're not going to see that intercostal space, so you shouldn't be seeing the pleural line. Thanks for your attention, and keep scanning.
Janice, thank you. That was an awesome case. You've been doing POCUS for a very long time, and if you could reflect a little bit on your experience, would you mind sharing with us some of the things that you wish you would have done or you wish you would have learned when you first started scanning?
It's hard to put it that way. It's been a long kind of, it's been a long process, and and I kind of look back on it and I more look at the things that I was glad that I did. The first one, I think a lot of people have alluded to the fact of being humble about your POCUS. You do get better every year, every POCUS you get better. And if you don't know, then you don't know. It's really good to, it's nice to not have to look back at those cringeworthy moments where you said with absolute surety that something was there and it wasn't. Not that that necessarily leads to bad things. I once saw a large pleural effusion that I thought was a pericardial effusion, and got a woman a cardiologist evaluation that she really needed and wouldn't have gotten otherwise. But mostly it's nice not to have those cringeworthy moments. The other thing is find your friends, find your people in your institution who also do ultrasound. Now that can be, if you have friendly ultrasound techs, that's great, or cardiologists, but it's really nice to find somebody who's in the process of learning how to do bedside ultrasound, and then you can nerd out with them, and that can keep you excited, and then you can also avoid making mistakes, and you can also make more mistakes, but in general, you can avoid making mistakes because people aren't going to make exactly the same mistakes. Thanks for the question. That's great. Thanks, Kang.
All right. Well, thank you again, Janice, for that awesome case. Up next is Dr. Mike Wagner.
Hi, I'm Mike Wagner. In this quick talk, we'll discuss incidental renal findings when performing point-of-care ultrasound. I don't have any relevant financial disclosures to make. We'll start off with a case. So here you are, you're in the clinic seeing patients with residents. You've recently taken the excellent ACP outpatient hands-on POCUS course, and you've been scanning pretty regularly and starting to get comfortable teaching as well. So you have a patient who comes in. She's a female in her early 40s. She's obese with metabolic syndrome, has some psychiatric issues as well as some substance use, which has been in remission lately, and except for some ongoing tobacco use. And now she's having abdominal pain. It's worsened by food and sometimes associated with nausea and vomiting. Her vitals aren't terribly concerning, and her exam is pretty unremarkable except for mild tenderness to palpation, but certainly nothing that's that bad. So you decide to evaluate further with point-of-care ultrasound. Your resident's helping you and commenting on the exam, gets a right upper quadrant home screen view here, and notices that the liver looks a little bit echogenic. And then you start to mention this to the patient. She reminds you that you worked up her fatty liver a year ago with negative hepatitis panels and everything like that. So then you and your resident shift your attention away from that, and your resident confidently looks at you and says, no free fluid, no hydronephrosis. So then you fan the beam anteriorly, looking at that gallbladder, and you see that there actually is some stones inside that gallbladder with acoustic shadowing. So you can see that right about here, right there, with acoustic shadowing coming off. So then you feel like you're kind of making progress on your examination. You go over to the left side for completion, and you see the resident's like, I don't see any, fluid around the spleen or any splenic enlargement, but looking at that kidney, something about that kidney doesn't look right. And you get another clip of it, and you're fanning back and forth just to make sure, but something's just not a lot of dopamine's going off in the brain. You're kind of seeing this irregular contour to the kidney. The visceral fat doesn't really surprise you. You've seen visceral fat around kidneys before, but the resident is looking at you like you have 5 heads, and they're not happy. So then flash forward to a different patient who is presenting with abdominal distension. She's a diabetic, former tobacco user, but you helped her to quit 2 years ago. Her traditional exam is also unremarkable, and you and the resident are also performing point-of-care ultrasound. So here we're seeing a very enlarged looking liver. It sort of jumps out at you as well here. No free fluid, but the liver is kind of quite large. And then the kidney, as it's being fanned through, appears grossly normal, but there's no evidence of any hydronephrosis on that side. So then on the left-hand side, the resident's kind of scanning through, and again is kind of like, ugh, I don't see any hydronephrosis, but there's something not right about this kidney here. And then they begin to wonder whether or not it's going to kind of continue to happen all day with you here. So there's that kidney again. You're noticing, there seems to be, again, this irregularity right around here. So going back to patient A, you have to decide what to do about that left kidney. So your resident looks at you and says, just complete deadpan face, it might be a tumor. And they follow that up with, I think we need to get a CT or at least a total abdominal ultrasound so we can at least get kind of the gallbladder and the left kidney and kind of knock it all out. And that's when you get to lay down your knowledge and say, actually, no, it's not a tumor. It is what we call a dromedary hump of the left kidney, or sometimes referred to as a splenic hump. And so it's felt to be an effect of the spleen on the kidney on formation, and it's as a result, it's a normal anatomic variant. This bulging tissue in question should really only be seen on the left kidney, therefore. It should never be seen on the right-hand side. And that bulging tissue should display an underlying normal architecture as well as ecotexture. So those two categories are met here in this image. I'm going to circle back to the blood flow in a second. So then with patient B, your resident says, okay, got it. This patient has a focal bulge on the left kidney. It's that camel thing, and therefore it's not a tumor. So what do you think, doctor? Do you concur with the resident assessment? Hopefully you don't concur because it is or was a tumor. All right, and so here you have the two side by side. Here you have the dromedary hump. Here you can really sort of get a sense of that sort of outline right here versus the kidney mass here. This is the renal cell carcinoma kind of invading into the cortex. It has a different echogenicity than the cortex. It has multiple little, almost like punched out little lesions. It's very easy to see in person, a little bit more challenging to see on the downloaded computer. This is the video of the dromedary hump, and this is the renal cell cancer for comparison right next to it. So the key thing with the POCUS integration here with patient A is to recognize the problem is probably the gallbladder and the gallstones. Still do the appropriate workup and evaluation as usual, of course, and help expedite their care, and then ultimately get them to either definitive imaging and surgical consultants. Patient B, they have this hepatomegaly. That certainly could be explaining the distension. It doesn't look like they have ascites, but that certainly needs a workup. But also that left kidney mass, that is certainly a concern. And that should get additional imaging and possibly a biopsy, but often they'll do a straight to nephrectomy when it looks suggestive like that. And that's what their CT did show, and they are scheduled for nephrectomy. So circling back to Doppler for masses in general and renal masses in particular, maybe it's because I haven't done the work to become technically excellent with Doppler, but I find that with most POCUS devices, the flow pattern you see with their standard presets is almost never helpful. And second, sometimes renal masses are so obvious you can't help but notice them, like this one here, giant renal mass compressing the kidney here. And sometimes it helps you with your workup, like in this case with a patient with cough, just with one shot, we knew that they had an effusion, that the effusion was likely malignant, and that the primary was probably the kidney. So sometimes it's really helpful and obvious. But some final points, even though I spent the last several minutes talking about renal masses, we generally don't consider this to be a core internal medicine skill set. Certainly if you scan enough kidneys for obstruction, or if you do it as part of a routine exam, you will come across normal anatomic variants and incidental findings. And if you do see a definite mass, things like distorted architecture and abnormal echogenicity can be helpful, but really shouldn't be solely determining your management. And I think it's helpful to become familiar with these things, but I don't think internists should fear scanning the kidneys for things like obstruction because of the issues with the masses or cysts and incidental findings. And finally, patient B could just as easily have had a renal abscess if she had fevers and pyuria and sepsis. And so, of course, you'll, as the clinician, allow the clinical circumstances to guide your image interpretation. So hopefully you found that helpful, and let me know if you have any questions.
Great, Mike. Thanks. Thanks for that. Looks like in the chat we've typed in a lot of online resources. Mike, are there any live courses coming up for those who are interested? Mike, you're going to have to unmute.
Rookie mistake. So thank you. Yes, there are, in November, ACP is returning to in-person hands-on courses. So Dr. Dave Tierney and Noel Northcutt are running the Introduction to POCUS pre-course, and there's 2 opportunities to do a 2-day introductory pre-course. And then if you have an outpatient slant, there is the considered outpatient or advanced POCUS course that's available, and that's November 15th. That immediately follows those 2 introductory courses. So hopefully we'll see you there.
All right, great. We got one more. Thank you, Mike. We got one more. And this is Nikita presenting. She is a fellow at Cornell as
well. Hi, everyone. My name is Dr. Nikita Ravelo Pagan, and today I will be talking to you about an interesting case I found on one of my shifts, and I titled it Cardiac Surprise Aided by POCUS. Let's begin. I have no conflict of interest to disclose on this presentation. We start off with the case of a 93-year-old female patient who arrived to the ED with shortness of breath on exertion that progressed to rest. She was also confused and had a transient left-sided weakness that resolved in the ED. Her medical history is pertinent for heart failure with preserved ejection fraction, arterial hypertension and hyperlipidemia, major depressive disorder, breast cancer on fulvestrant, and a remote history of colon cancer. Blood pressure was 130/55 millimeters of mercury, heart rate was 114, and respiratory rate of 13. Her physical exam, she was elderly, well-kempt, but chronically ill. She had no JVD. Her heart sounds were a little distant. She had positive bowel sounds. The belly was soft and depressible. Her extremities were warm, but she was confused, and she had mild paresthesia on her left antibody. In the initial encounter in the ED, the working diagnoses were TIA versus stroke due to her transient paresthesias and her confusion, and the decompensated heart failure due to her previous heart failure diagnosis. Head CT was ordered. She was started on Lasix IV, and she was admitted to internal medicine. The head CT was negative for stroke. Her paresthesias had already resolved, and in the internal medicine encounter, point-of-care ultrasound was applied. This is a surveillance scan to evaluate the posterior structures of the heart. And you can see here that once the image is adjusted to the adequate depth, we can see a pericardial effusion and an underfilled RV with thickening of the wall and irregularities. The first image acquired was a parasternal long. We used a cardiac probe to see the cardiac silhouette. Once in the correct position, we found that there was a significant amount of fluid around the heart, but there seems to be a circular structure here that we can't really delineate where it's coming from. I can point out the RV and a little bit of the LA, and then maybe we can see a little bit of the LV right here on the bottom. The second image we acquired was the parasternal short. We do that by rotating contralaterally. We can see still here that there is pericardial effusion around the heart. most prominent in the superior portion. And you can also see that the RV is underfilled and there is irregularities in the wall. Maybe because it's underfilled or maybe because there's fibrinous strands around it. This is an apical 4, just as a caveat, is a little rotated, but you can see that there is a pericardial effusion. You can also see enlargement of both atria, more prominent the right one, and an underfilled right ventricle with the irregularities of the wall that were present on our parasternal short. I decided once again to return to parasternal long just to pay attention to the structure that we saw on the first slide of the POCUS scan, which didn't seem to fit the normal anatomy of parasternal long view. As you can see here, this circular structure is filled with fluid and it seems to be close to the base of the heart. We can also delineate under it the LA and one of the pulmonary veins just draining into it. My first differential diagnosis was pericardial cyst. These are not very common, but we can definitely think of them once we're seeing fluid-filled structures around the heart that are not pertinent to the normal anatomy. I added this image right here where you can see it in the asterisk. There is a fluid collection. It's around the heart. My first differential diagnosis was pericardial cyst. These are not very common, but we can definitely think of them once we're seeing fluid-filled structures around the heart that are not pertinent to the normal anatomy. I added this image right here where you can see it in the asterisk. There is a fluid collection. It's around the heart and it's not surrounding it completely, but you can see that the labeled structures right here are pertinent for the chambers and there is significant amount of fluid just enclosed in one area. So it could be potentially that our patient had a pericardial cyst closer to the base of the heart. Another one of my differential diagnoses was a complex pericardial effusion. You can see here in the image that there is a hyperechoic lesion that's circular and there is underlying fibrinous strands around the pericardial fluid. In the case of our patient, these irregularities were only seen on the RV, so I thought it was less likely, but definitely something to think about when we're seeing pericardial effusion and fibrin depositions or irregularities in the border of the wall of the heart.
Sorry, everybody. We're just having technical issues here.
My third differential diagnosis was cardiac tamponade. I added this image here for your reference. You can see the pericardial effusion right here, and there is significant amount of collapse of the ventricular wall on diastole. In the case of our patient, we didn't have the EKG leads to confirm a tamponade. Also, clinically, the patient was not in tamponade, so that helped rule this out, but it's definitely something to think about once you see pericardial effusion. My last differential diagnosis was aortic dissection, especially because the patient had confusion, the diastolic pressure was low, and also there was this cystic lesion or structure that could have been a dilated aorta or aortic root. So this was definitely something to consider, and it would totally change management in case that it was an aortic dissection. As far as discussing the point-of-care ultrasound performed bedside, I decided to return to the initial image and pay a little bit more attention to the structures surrounding this circular structure that was found in the initial encounter, and I found that it was confluent with the aortic root and the aortic valves, as you can see here, which I'm pointing to right now. So this was definitely a turning point in the diagnosis, and this patient was found to have a dilated aortic arch and root. This is another view of the circular structure that we found out. It was an aortic root dilation with an aneurysm. So you can see here it's very prominent and it's coming off from the base of the heart, just so that you can take a better look at it. As far as case resolution for management, the patient was started on IV fluids. We decided to stop the Lasix just because this patient needed volume. A chest CTA was performed, which was negative for an aortic dissection. The patient needed constant cardiac monitoring. There was a 2D echo performed. We consulted CT surgery because the 2D echo and the chest CTA showed this massive aortic root dilation, and after consulting CT surgery, the patient declined surgical intervention. For the final diagnosis, we found that the patient had a pericardial effusion with RV underfilling and an aortic root aneurysm of 8.1 centimeters. So the take-home points I want you to leave with today are, first of all, patients presenting with symptoms of decompensated heart failure might not always benefit from diuresis. So this is something that you need to keep in mind once you're examining patients. And if you definitely have an ultrasound machine close to you, you can scan this patient and basically decide if diuretics are in need or not. The other point I would like to discuss is neurological symptoms in patients with aortic aneurysms are high concern for aortic dissection, as in the case of our patient. Luckily, she didn't have a dissection, but she did have a significant aortic aneurysm that was considered for surgical repair. Another thing would be and valves can actually help you identify the structures better and determine if there are dilations, cysts, or other structures that might not be related to the cardiac silhouette. And last but not least, cardiac tamponade should be ruled out with EKG leads and cardiac imaging in M mode for patients that have new onset symptoms and have a pericardial effusion that was not there before. Thank you so much for your attention. I hope that everybody enjoyed this case as much as I did. It was super interesting. And now we will open the floor for questions.
All right. Well, thank you again, Nikita, for that wonderful presentation. I apologize that some of the clips didn't play.
I'm sorry too.
Yeah, I was going to ask you, you're completing your POCUS fellowship, and how many cardiac normal versus abnormal images did you have to acquire before you felt confident with your skills?
Well, definitely a lot. We have to complete a portfolio once for training. We usually get around 20 images of normal anatomy. So I would say that more than 20. But before that, we get an intense training in order to visualize the images and then optimize our technique to better acquire these images. So definitely, I echo the voice of other specialists that have spoken here. Once you start scanning, you shouldn't stop. You should always continue to scan in order to get better and perfect that technique.
Yeah, I totally agree. Well, this is it. And, thank you so much for our presenters for presenting these really excellent cases. I've learned a lot along the way. Hopefully you all have found something helpful, and that you found this webinar helpful, and keep on scanning, everybody. Have a good evening.